Hey Jack, patient assessment trauma. You're dispatched to the logging yard for a male that has amputated his leg.
Okay. BSI is my sensei.
Yes.
Mechanism of injury. Do we have an amputation? Was it heavy equipment?
Yes. Yeah. Heavy equipment.
Okay. So I got mechanism of injury. This is my only patient. I'm going to consider calling additional resources if needed, and I'm going to consider C-spine precautions.
Okay. So you walk up to the patient. He's laying supine. He's pale, cool, diaphoric, skin color looking. Bystanders are holding towels and shirts to him. They're soaked in blood, and you notice a large pile of blood under him.
Okay. So general impression, we got a large bleed, a life threat. It's dangerous. Patient's not doing well. I'm going to address the chief complaint and any immediate life threats. It appears that there's an amputation of the left leg. So I'm going to place a tourniquet there at this time.
Okay. Bleeding's controlled with your tourniquet.
Awesome. So after that, only chief complaint is going to be that missing leg. I'm going to kind of start moving into my ABCs here. I'm going to see, check the airway here. Is he talking, responsive with me?
Yes.
Okay. So airway is good. I want to assess his breathing, make sure that he's breathing at appropriate rate, volume, depth, things like that.
He's good.
Okay. Gonna check circulation, check pulses, skin condition. How's the skin?
Pale, cool, diaphoretic.
Okay. Pulses.
Rapid, regular.
Oh, perfect. And then so any additional bleeds, I'd be looking for that and just overall circulation. From there, I'm going to move into history taking. I'm going to have my partners working on history taking and vital signs.
Okay.
With a priority on blood pressure, pulse, and SpO2.
Okay. All of those are what you would expect.
Okay, perfect. So from there, I'm going to move into my assessment. I'm going to start at the patient's head. During the assessment here, I'm going to start with a full hand on the back, working around, checking facial structures, make sure that everything's intact. Do I find anything?
No, you're good.
Okay, pupils,
Equal and reactive to light.
perfect. I'm moving down, I'm palpating the back of his neck, side of his neck, shoulders. I'm looking at his trachea and looking for JVD or tracheal deviation.
We're good there.
Okay, moving down in the chest. I'm going to push down the center of his chest and on the chest wall. No complaints of pain.
Nope.
Okay, palpating through, don't find anything.
Nope.
Okay, moving to the abdomen. I'm going to visually look, see if I have any sort of bruising, distension, any obvious pulsating masses, anything crazy. I don't have that, so I'm going to begin palpating. Go through my quadrants, do I find anything?
No.
Okay, moving down the pelvis. I'm going to push in, and I'm going to push down. Do I feel any movement?
No, he's stable.
Okay, moving down the left leg here. I have a tourniquet in place. I won't be able to set CMS past that point. Do I have any bleeding? Is it still controlled?
Still controlled.
Perfect. Moving to the right. I'm going to go down the leg, palpating. Do I have any additional injuries?
You notice like a 6-inch laceration that's just kind of oozing blood.
Okay, kind of a venous bleed there.
Yeah.
I'm going to direct a partner and get some pressure on there. We'll just wrap it. That's something we'll come back to and reassess further along the line. At this point, I'm going to get the patient rolled. We're going to roll opposite of the affected limb there. So we're going to roll to the patient's right.
Okay.
We're rolling up with C-spine being minded. It doesn't seem necessary at this point based on the mechanism of injury. But I'm going to go through, palpate the spine, poke the spine test. Do I find anything?
No.
Do I see any additional bleeds or anything like that?
Negative.
Perfect. We're going to get rolled back onto a board just to help with transferring them over to the gurney. At this point, I'm assuming the patient's in pretty extreme pain.
Yes.
Okay, so I'm going to start 2 large bore IVs. I might start one with my partner, start another. We're going to run one with LR. We'll do 20 mils per kilogram at this point, just kind of a maintenance thing. And then we'll end up with 1 mic per kilogram of fentanyl, just to help manage the pain and alleviate some of that for this patient. After that, this is a priority transport. I mean, GCS is 15, but still priority transport that needs to get going, so we're moving. And I'll just be reassessing, making sure that all of my interventions are in place. We'll reassess the tourniquet after movements to the ambulance and things like that. So
Cool. Good job.
cool.